Hello. Today we are discussing problem lists, and I'm going to start right off with its definition. A problem list is a prioritized list that includes all aspects of a person's current pathophysiologic state, medical history, family history, and social history, which either need to be addressed at the moment or which might impact the patient's health at some point in the future. What kind of items might one potentially find on a problem list? Obviously, symptoms such as headache, diarrhea or dysuria, etc. Exam findings like abdominal distension, heart murmurs, and an unstable gait. Test abnormalities, including both conventional lab tests, radiology tests, and others. Chronic medical and psychiatric conditions. Old, seemingly resolved problems, which could recur or cause later complications. For example, a history of splenectomy, because it will place the patient at a greater risk of acquiring a few specific infections, and a history of cancer with no current evidence of disease. This does not mean every seemingly resolved problem. For example, if someone had appendicitis 5 years ago, had an uncomplicated appendectomy, and it's been fine ever since, that does not go on the problem list because that is very unlikely to impact the patient's health in the future. High-risk medications. This is largely limited to chronic immunosuppression. I've heard some suggest that anticoagulants like warfarin or DOACs should be included here too as items on the problem list that are separate from their indication, but in my opinion that's overly inclusive of what's considered to be a distinct problem. Active or previous substance abuse. Significant family history of hereditary disease. This category can be particularly subjective since a lot of common diseases have genetic components, such as diabetes and heart disease. But you should limit this category to a family history that will substantially change how you approach the patient's care. For example, if a female patient's mother had breast cancer at the age of 70, that does not belong on the patient's problem list. But on the other hand, if the patient's sister developed breast cancer at the age of 35 and is also known to have the cancer-causing BRCA1 mutation, well, that definitely does belong here. Likewise, a situation like having a parent with Huntington's disease, since the risk of the patient inheriting that fatal condition would be 50%. And the last category is highly significant social factors, such as poverty, lack of medical insurance, home violence, and homelessness. What's the purpose of a problem list? Problem lists have two major purposes. First, they drive actions. Anything that's listed on a problem list requires some form of plan, even if that plan is something like continue observation or recheck that abnormal test result in another 2 weeks. If an item is on the problem list that does not have an associated action, either an action is missing, or the item maybe shouldn't be on the problem list in the first place. The second purpose of problem lists is that they rapidly communicate between clinicians in a way that blocks of prose don't. Prose, like summary statements, help to convey a clinician's thought process, but when in a situation that's more needing rapid communication of action items, a list is more effective. Plans for patients should always be organized as problem lists in the medical chart. Depending on the specialty and the role of the writer, a list might be very comprehensive, or it might lean towards being streamlined to only the most critical problems or those most relevant to the writer's specific role, for example, if they're a consultant. And in critical care medicine, the problem list is typically organized by organ system rather than by discrete problem. But every physician note should include a problem list in some form. To show what I mean, let's consider the assessment and plan from a hypothetical note. So imagine we are admitting a patient whose assessment, that is, whose summary statement, reads as follows. 47-year-old woman with a history of diabetes and medication non-adherence, secondary to lack of insurance, who presented with intermittent palpitations and acute positional dyspnea, found to have evidence of moderate volume overload on exam with an ECG showing new onset atrial flutter with ventricular rates in the 100s to 150s. What might this woman's problem list and plan look like? Problem number 1, suspected heart failure, for which we'll be obtaining an echocardiogram, diuresing with furosemide, switching outpatient amlodipine to lisinopril, and getting a nutrition consult. Problem 2, atrial flutter. For this, we'll have her on telemetry and be giving IV metoprolol, initiating a DOAC for anticoagulation, and referring her to EP to consider outpatient ablation. Problem 3, diabetes. We'll check a hemoglobin A1C to see how well it's been controlled recently, and we are placing her on a conventional basal bolus sliding scale insulin regimen while she's in the hospital. Problem 4, for her lack of insurance, we'll be consulting social work. And last, if hypothetically her father was diagnosed with colon cancer at the relatively young age of 45, we would arrange for an outpatient screening colonoscopy for her. Unless in the role of a consultant, problem lists should generally be comprehensive. For a comprehensive problem list, every symptom, current medical or psychiatric problem, physical exam finding, and test abnormality should be accounted for somewhere. But that definitely does not mean that each thing should be listed separately, which brings me to the consideration of lumping versus splitting. Problems should be lumped together as one if there is one common underlying pathophysiologic process behind them and there is a common approach to treatment. Otherwise, keep the problem split, meaning list it separately. Let's look at some examples. Imagine a patient's problem list includes dyspnea, lung crackles, elevated JVP, elevated BNP, and lower extremity edema. Assuming there was no reason to suspect alternative explanations for these findings, these should all be lumped together as one problem, framed either as heart failure, suspected heart failure, or most generally, intravascular volume overload. Let's take a different list: pancreatitis, a cranial nerve 6 deficit, a recent DVT, psoriasis, and a low MCV seen on a CBC. These problems do not have any obviously shared pathophysiology, and they certainly do not share treatment. Therefore, they should be split, meaning listed as separate individual problems on the problem list. So far, these two examples have been straightforward, but the optimal way to lump versus split is not always that obvious. Consider this list: a history of celiac disease, weight loss, hypocalcemia, anemia, and lower extremity edema. A first-year student with only superficial knowledge of celiac disease might see these as all unrelated. Someone a little further in training might know that celiac disease can lead to weight loss and anemia, so they might lump those and leave the others split, while a senior medical student might realize that the lower extremity edema could be from hypoalbuminemia, and the hypocalcemia can be from celiac-related vitamin D deficiency, and thus they might lump everything together as celiac disease and its various complications. So the decision to lump or split depends upon one's knowledge of pathophysiology. To add another layer to this specific list, it also depends upon whether one has fully ruled out other explanations for individual items other than the primary lumped problem. So for example, what if you felt confident that the weight loss, anemia, and edema was all related to the celiac disease, but you weren't sure yet about the hypocalcemia? If you were also concerned it could potentially be from something like autoimmune hypoparathyroidism, for example, well, in that case, you would leave that one problem split for now. Let's look at one more example list: pneumonia, sepsis, dehydration, acute kidney injury, and hyperkalemia. How might we lump and split these problems? Well, we could say that pneumonia and sepsis are both related to infection, while dehydration, AKI, and hyperkalemia are related to volume status. Alternatively, we could consider the last two problems as, kidney stuff, or we could make the approach to treatment the most important factor, in which case pneumonia and sepsis are treated with fluids and antibiotics, dehydration and AKI is treated with just fluids alone, and hyperkalemia has a whole collection of specific potassium-lowering therapies. In this example list, different approaches to lumping versus splitting were not dependent upon a different knowledge of pathophysiology, but rather upon a different opinion on how the problem should be framed. There is no one right way to lump and split this particular list, and this will be the case with many patients you'll see in real life. Another aspect of problem lists is that they must be prioritized by importance and urgency. Usually, though not always, the chief complaint will be incorporated somehow into the first problem. If we return to our early assessment and plan for the 47-year-old woman with a suspected heart failure, we can see a good example of how to prioritize a list for an inpatient. Here we have 5 problems: heart failure, atrial flutter, diabetes, lack of insurance, and family history of early onset colon cancer. The earliest listed problems are those that must be addressed immediately. The next are those which need to be addressed during the hospitalization, but not necessarily at this exact moment. And last are problems that can be deferred to the outpatient setting. The last major point to make about problem lists is that they are dynamic. Problems get removed, added, renamed, or reframed as new information becomes available. Problems get reprioritized as their importance rises or falls relative to other problems. And initially separate problems can get lumped together if it's established that they are due to the same underlying etiology. The key takeaway points for this video: a problem list includes all aspects of a person's current pathophysiologic state, medical history, family history, and social history, which either need to be addressed at the moment or which might impact the patient's health at some point in the future. Problem lists are an integral part of the medical record. And a good problem list is comprehensive, is accurately prioritized, appropriately lumps and splits, and is dynamic.